Hello, and welcome to the Clinical Care Options Infectious Disease podcast. I'm your host, Jessica Adams. This is one of 4 regionally focused episodes on what patients want in HIV treatment and prevention. This episode features a conversation between Marc Thompson and Dr. Tristan Barber from the United Kingdom. Marc Thompson is the director of the Love Tank and co-founder of Prepster in London, UK. And Tristan Barber is an honorary associate professor at the Institute for Global Health at University College London and a consultant in HIV medicine at the Ian Charleson Day Centre at the Royal Free Hospital in London, UK. In this episode, they'll discuss some of the barriers to genuinely patient-centered HIV care in the United Kingdom and offer calls to action for healthcare professionals for responding to patient preferences. For the full online educational program, please visit the link in the show notes for this episode. Now let's get started and hear what Marc and Tristan have to say.
Hi, Tristan. It's lovely to be here with you to have this conversation today.
Great to be here with you too, Marc.
We've got some really interesting things to talk about when we consider, what patients want from treatment and prevention. And I suppose one of the key places for us to probably start is the beginning and thinking about testing. We can talk about engagement in services and what some of the solutions are, but I thought it might be a good idea for us to just start with the basics, which is around getting tested and what it means to be tested and what some of the barriers are. And should we just start off by just having a conversation about what you have seen as some of the barriers for people engaging in testing?
I think that's a really good place to start. I think we've had a lot of success in the UK with our national health system in terms of rolling out HIV testing, particularly for high prevalence groups. I guess men who have sex with men have been very well targeted by testing and prevention messages in our system, particularly with our network of sexual health clinics. But I think for some other groups, it may have been more difficult to find the right setting to test in. We certainly know that migrant groups, for instance, may not know about our sexual health services. They may not always be offered HIV tests when they attend a primary care service or a general practitioner service. And what we see increasingly now is that we have about 5,000 people in the UK who are not aware of their HIV diagnosis still, despite us being one of the best countries in the world for achieving the UNAIDS 95 targets. And what we know is that these 5,000 people are probably from much lower risk groups traditionally for HIV. So when we see people with misdiagnoses now who come into the hospital, they're often heterosexuals, middle-aged. They may never have seen HIV testing or prevention messages as being particularly targeted at them. They may not have seen people who look like them in poster campaigns or TV campaigns. And so I think we're going to have to spend a bit more money to find the best ways to break down the barriers and make sure that these people can be tested in the right place at the right time for them, to make sure that we pick up these final diagnoses and really make sure that we get to zero HIV transmissions by 2030. But you must have seen some barriers to testing as well. What can you tell us about testing barriers and facilitators within our setting, Marc?
Yeah, you're absolutely right, Tristan. I have, and coming from, a grassroots community-based perspective, I think the example that I would give is that we have seen great strides in testing and diagnosis in men who have sex with men over the past few years. But even when we're drilling down into those numbers, we are still seeing gaps, as you have mentioned, but in migrant queer men and also men whose first language isn't English. And surely that has something to do with the system, because these men know that HIV testing is the right thing to do. They're probably not as stigmatized about it as some other parts of the community, and they certainly know that HIV is part of their world. But I think some of the evidence that we have is men either not understanding how healthcare systems out of their home countries may work, and that's not just in the UK, that's wherever they might migrate across Europe. Then also when they get into clinic, there are language barriers as well. So if English isn't your first language and the practitioner you're seeing only speaks English and translator or interpreting services aren't available easily to you, then that may prevent you from going in and getting tested. But where I do think it has worked and we've demonstrated really good practices, as you kind of alluded, is going into community itself, is taking testing away from clinical settings, providing it online so people can order test kits, can do stuff at home or away at a time that suits them. So I think there is a real work that we need to do to ramp that up and to invest in that. And also looking, which I think we'll talk about a little bit later, is how can we engage with peers from those communities to encourage and engage with others to test.
Yeah, those are excellent points. I guess some of what I see as well is that we're still a bit better about many of these issues in urban metropolitan areas than we are in perhaps rural places or smaller towns and cities where HIV has maybe not been on the radar quite so much historically. So I guess we have to think about geographical leveling up as well as thinking about specific communities. I did have a thought which it'd be good if you could comment on, which is I guess some communities as well understand the benefits of testing a little bit more than others. So I know we keep defaulting back to men who have sex with men, but perhaps those messages have got out there a little bit more in those communities that, you know, there are benefits to knowing your status, which can be having a normal life expectancy, getting access to healthcare, knowing that you can be undetectable and not transmit your virus sexually. So fulfilling the U equals U, undetectable equals untransmissible statement, perhaps enhancing your sexual enjoyment, protecting your sexual partners, knowing that you can't pass HIV on. So perhaps these positive messages about knowing your status penetrate better into these communities where they've best been and mostly been targeted historically. What do you think?
I absolutely agree with you, Tristan. You know, we have come light years from when we were not promoting testing to men who had sex with men at all. You know, I'm old enough and have been around long enough to remember the days of the epidemic where getting a test meant, you know, you couldn't get health insurance, you couldn't get housed. All of these things were going on. And we've moved light years away, and lots of gay male communities have understood that. And to test is now seen as a very healthy behavior. If you go onto dating apps, you can put down that you're tested and when you were tested. And I know that many gay men, particularly younger gay men, now understand that you are only as negative as your last HIV test. I hear people say that. But when we widen the lens, as you have mentioned, and we're thinking about, say, Black African communities or migrant communities or communities of heterosexuals or women, that conversation hasn't been had. And there's still lots of stigma around HIV, outdated ideas of what it means to be diagnosed and have a positive diagnosis. So I think we absolutely have to change that narrative. I recall doing some work on a campaign a few years ago where we were getting positive people to talk about the benefits they'd experienced once being tested. So I think there is some real work that we need to do. But Tristan, what I'm also really interested in, because we've spoken about campaigns and we've spoken about testing, but one of the things that I challenge my colleagues these days about is to think outside of our own scope and what I call our HIV bubble. So the people that we want to reach of those 5,000 are not usually engaging in sexual health or HIV services or seeing campaigns. So we should be working more broadly with groups that are managing victims of domestic violence, people who are homeless, people who have drug and alcohol issues, and not only just raising awareness in those spaces, but maybe training those people that run those services to conduct HIV testing. And also, finally, I would say on this point, that I think it's really important now that we start to take a much more holistic approach to testing. So if I'm thinking about, say, Black male communities, heterosexual men, we can go and offer HIV and STI testing in barbershops and places where those men meet, but they're more often than not going to turn that down. Whereas if we made the offer around blood pressure checks or a conversation about mental health, oh, and by the way, we're offering HIV testing, I think that could be a really interesting and exciting way to bring new people into the fold. What do you think?
Yeah, I think that's a really, really great idea. I think sometimes there are barriers to implementing testing in other environments. I know we've certainly tried to implement testing in cervical screening services so that more women get tested, particularly in rural areas. And we have had some pushback from people saying, why is this my role? I'm going to scare people that weren't thinking about HIV. They came in for something else. But actually, when you look at surveys of people who use these services, often they say it would be very acceptable to be offered something that would be good for their health. So I think we must be careful about being paternalistic or protective about environments that we think may or may not be right for testing. And what we really need to do is educate other practitioners again, about the benefits, really, about testing people and about them knowing their status. I think education really of providers as well as of people with undiagnosed or potentially undiagnosed HIV is incredibly important. And I think what we've coalesced on there is actually making people realize the benefits of knowing your status, and some of the outdated ideas we see in healthcare professionals, that we see in surveys of healthcare professionals, reflect some quite old-fashioned beliefs, which may feed into that negative stigma that, knowing your status may mean you can't get insurance or you can't get certain jobs, when in actual fact, the positives far outweigh those old-fashioned negative and stigmatizing views that persist in the minds of some people. So I think education of communities and of people, but certainly of providers in different environments, is incredibly important.
So once somebody has got tested and they test positive, the next step is obviously engagement in care. And one always thinks when we occupy this HIV bubble sometimes that that's a really easy journey for somebody, but we know the engagement in care. Now, you're a clinician. I work on people on the ground as well. What have you experienced in terms of the barriers for engaging and keeping people in care?
Wow. I mean, I think the barriers can be multiple. We see a lot of issues of intersectionality here, really, I think. So there can be issues of understanding about HIV and the need to engage into care, issues that we've touched on already, which may be around what the benefits are of receiving treatment. It's lifelong treatment. For some people, this is quite a head shift to get their minds around that they're going to be taking treatment for a lifetime, potentially. I think also location of services is very key. We know that some people have more resource, they have more agency, if you like. They can travel around urban cities, they can find the right clinic for them, they can find the right service that suits their needs. Other people may have lower access to finances, they may find traveling long distances very difficult, they may have disabilities. All of this may impact on their ability to really engage with care. So I think there are issues about health literacy, there are issues of socioeconomic status, there are issues of the specialty areas of certain clinics that may appeal to certain different communities, people from certain different demographics. I think there are issues of staff mix as well. We know that some people like to be seen by someone who looks like them, who understands their issues. Some women prefer to be seen by female practitioners, and sometimes vice versa. We know that we need good racial diversity within our clinics to make sure that all the people affected by HIV can see that the diversity of people living with HIV is reflected in their teams. And then I think there are some actual practical barriers to engaging with treatment. If the phones aren't answered at reception, if you have disclosure issues at home and you want someone to send you an email or a text rather than phone you up because you can't speak freely, and then your doctor says, I don't give people my email address, that can be a barrier to discreet communication. So I think there are some cultural community factors, some technological issues, socioeconomic issues, issues of stigma, including self-stigma. And I think with the evolution in who we're now diagnosing with HIV, we can't rest. We have to continually look at how we adapt our services to make sure that we are engaging with the change in the demographics of who we're diagnosing and who we need to form relationships with.
I mean, I completely agree with that. And what I also think is interesting from the other end of the spectrum, because you're absolutely right about people who are being newly diagnosed now or in the past few years, and that demographic is changing. I certainly saw in much of my work when I was developing peer support that many people from Black, African and minority communities were disengaging with care. And that had a lot to do with internalized stigma, as well as the setup of some of the clinical spaces they were going to. But what I always found beneficial was to work directly with healthcare professionals in clinic to look at the services they were providing, to try to understand if they'd engage with peer support or peer supporters, so people who were living with HIV and had lived experience can offer another layer of support and education and information to the individual who's coming in. Now, I go to a central London clinic, which is very, very popular with gay, bi, and other men who have sex with men. And it absolutely suits my needs. There have been occasions where I've had to go to another clinic in South London, and the experience was completely different. I mean, totally different. And that had a lot to do with resourcing, the fact that it was quite a generic clinic. So I was a HIV patient in a sexual health clinic with everybody with absolutely everything else. So I can understand why somebody who doesn't have the agency and the information and the privilege that I do may go to a clinic in their local area and be really frightened and feel really isolated and really disconnected. You've used peer supporters in your work, Tristan. How has that benefited your patients engaging in care?
I think peer support is immensely valuable. I think it's particularly valuable from the people that come from communities that may have felt marginalized or may have experienced high levels of stigma in the past. I have a large number of African patients in my clinic at the moment, as well as a large number of men who have sex with men. And I'm a white cisgendered man. So we have good rapport. I have good rapport with my patients, but from time to time, for them to be able to see an African female peer support worker and talk about things in a slightly different way is tremendously helpful. And I find that particularly useful at the time of early or first diagnosis, when there may be issues that they don't necessarily want to disclose to me. And I think what this really feeds into, for me, we often see feedback from service users that they like to see the same person regularly. And I think we understand that, you don't want to repeat your story every time you come to clinic. But on the other hand, I think it's very important that people have access to different people as part of that team, because they may experience different levels of comfort in sharing different aspects of their mental or physical health with different people. And I think I've also seen the converse where, when someone's seen the same doctor for 20 years, they will have built up a relationship that may mean that they're embarrassed to tell them they missed some tablets, or they're embarrassed to tell them they've got a genital rash, or that something's gone on with their mental health, because they almost don't want to change that relationship that they have with their regular doctor. So having something like peer support, as well as a very engaged nursing team who can notice when someone needs something a little bit different to what they've been getting, can be really, really useful. And that leads to truly, I think, holistic and person-centered care. The one other thing, if you'll allow me, I wanted to mention just about peer support is I think this is also an area that needs to evolve to look at the changing demographics of who we're seeing and diagnosing with HIV. I mentioned that we're seeing middle-aged heterosexuals now very often diagnosed rather than men who have sex with men. And I think we don't have always peer support workers that reflect that demographic, as opposed to perhaps African women or gay men, where they may recognize someone who's got a lived experience like them, because the heterosexuals we're seeing tend to be, for want of a better word, they tend to be Asian. So we're seeing a lot of Indian, Malaysian, Chinese, newly diagnosed people in their 50s and 60s, and we don't have good, well-trained peer support workers who represent that demographic in my current setting. So I think we have to just not rest on our, where we are. I think we have to continue to evolve, continue to train, and continue to try and find the right peer support workers for the epidemic as it evolves.
One of the things I just wanted to pick up on was around the impact of COVID. And we have moved very much, certainly in my clinic, to a lot of my appointments. I'm using apps. Everything I do is pretty much online. Did COVID throw up any opportunities or for increasing engagement, or did they just exacerbate the barriers?
I think COVID was quite mixed. I think COVID prompted some people who'd not engaged in clinical care for a long time to come back to clinic because they were concerned about the possible impact of their HIV on the severity of COVID if they were to get COVID. Other people, I think, were very frightened. They were frightened to travel. They were very nervous and they disengaged somewhat. And some of those people have still not come back to face-to-face appointments. What it has done, of course, is it's really forced through a lot of technological innovation. The NHS, which we can talk about because we're here in the UK, has a lot of bureaucracy and red tape. We've been very slow to innovate, I think, with technological changes. What we have seen now after COVID is that we're using texting, we're using apps so that people can be clinic ready and note their symptoms, using email a lot more. We were using some video conferencing to have virtual appointments. We're sending people out quality of life questionnaires. I think we have adapted our product, if you like, to try and make sure that people can do some things at home. But I don't think that completely means that you've lost the importance of a face-to-face visit, at least from time to time. And I think what we need to do is be better at working out who is very stable and can have an at-home stable pathway, if you like, and who is a bit more complex and actually needs to have more face-to-face engagement. So I would say it's been a mixed bag, if you like.
I as a patient and a person living with HIV, I'd like something which sits kind of in the middle of that. So right now I see my healthcare professional twice a year for a full kind of MOT. So my bloods, my viral load, my kidney function, everything done once, and then once a year just for viral load. But I would really love the opportunity to be able to see my HIV clinician a bit more frequently if I need to. But I understand that's not always easy to do, and I am stable. But I love the idea of something in the middle. But just thinking about that and kind of sticking with that coming into C, we know that many people who will be diagnosed today will start treatment pretty much immediately. Now, that's great news, but it also means that there are some within this cohort who will get a diagnosis, get treatment, and then go along their merry way and just get to undetectable. And I'm aware, and I know that you are, that sometimes that jolt can hit 6 months later and they're actually lost. What can we do to try to ensure that those people return to us and they're getting the adequate support and care that they might need?
I think this is really important. HIV care has moved to being much more biomedical at the time of diagnosis. I'm also sort of very aware that locally, I'm lucky, we've kept a very good psychology team. Many units have lost their psychologists, but I think the ability to be able to offer psychological support, particularly in the early stages after a diagnosis, is tremendously valuable and important. Now, the biomedical thing manifests in terms of, we see people, we tell them about fantastic treatment we can offer that's mostly very well tolerated. We tell them about U equals U, the fact that we can get them undetectable within 4 to 8 weeks. We give them tablets. They come in 2 months later and their viral load's undetectable. Now, for me, it's absolutely crucial at this time point you don't label someone as stable and send them off to be seen again in 6 months. If you're in the first year, maybe 2 years after a diagnosis, for me, that's still a period of immense flux. And even if your viral load is undetectable, I still want to see people every 3 months, really, maybe every 4 months if they've got a lot of friends with HIV and they're very HIV savvy. But I still want to see them a little bit more regularly because, as you say, some of those mental health issues may drop out maybe 6 to 9 months after a diagnosis when people think, whoa, what just happened? That was so fast and I was on treatment and this is my life now, and they really start to process things. And I think if at that point you say to someone, come back twice a year, it's not giving them adequate support. So I think there's a real imperative that when people are newly diagnosed, they need to not be seen as stable until they've got, I would say, at least through the first 18 to 24 months, even if their viral status is suppressed and you're happy with the biological aspects of their treatment. Before we had good antiretroviral therapy, you'd spend 2 or 3 years getting to know someone before you even suggested going on the tablets very often. And we're in the reverse of that situation now with modern approaches to HIV treatment.
So what I'm definitely hearing there is that we have to consider the needs of people right across their HIV journey, from newly diagnosed to getting stable to aging with HIV as well. These are really important things. And so moving on then, so, one of the key things once you've had your test and you've engaged in clinic is obviously treatment. And now we're talking about, you've mentioned U equals U, undetectable equals untransmittable. Treatment as prevention, how are we engaging with people there? And are people getting the message? I know, again, that the gay male and MSM community have started to really grapple with this, and it's a real reason for people testing. When I speak to guys who are newly diagnosed, their first thing is, I want to get on treatment. I want to get to undetectable. Then I can deal with everything else. What have you seen?
I think you're right. I mean, the U equals U message is tremendously important. And I'm going to blame myself here, because very often we think this, this job amongst HIV communities is already done. I've had 2 or 3 people in the last few months who, have sat here and said, someone told me I could have children now if I if I wanted to. And this, you can imagine the look on my face where I think, have I not told you about U equals U? I thought I told everyone. And we're sort of thinking about how we can better communicate U equals U with the doctors who work in our emergency department, or our surgical colleagues, or people that don't work in healthcare at all, who we think don't know the U equals U message. But I'm mortified when I've got someone sitting in front of me who has slipped through, if you like, our U equals U communications net. It's essential to keep communicating this message, because people, when they hear it, are very often in tears. It can be life-changing. Children certainly being at the top of the agenda for some people may have been something they'd written off the minute they had an HIV diagnosis. And being able to tell them that they could, if they want to, have their own children again is a tremendously life-changing and an emotional moment. So I think we must never rest in telling that message. We must never forget the impact and the importance of that message, even for the people sitting in front of us in clinic, let alone the wider population and wider communities.
And I think what's really interesting around the kind of treatments prevention and the U equals U message is that we have very often, and quite rightly, but a lot of emphasis on transmission during sex. And for many people living with HIV, that isn't their primary concern. And if I may, I'll just share an anecdote with you. I did some training a few years ago when we were really pushing the U equals U message. And there was a Black African woman in her early 50s. And she said, does this mean I can now invite my grandchildren over and I don't have to bleach the house? Because those were the risk prevention methods that she was taking. So again, the U equals U message and treatments prevention is so much broader. And I think we do need to be smarter, think about the intersections of people's lives and where U equals U fits into that. So it's great to show couples, it's great to show that, but if you're not having lots of sex, then you may think, well, actually, what is the point of it? Does it relate to me? So I definitely think we need to do a lot more thinking about that.
Yes, yeah, I agree. Wow, that's such an amazing reaction to hearing that message, isn't it? Really, really moving.
Yeah.
Mark, maybe I could go on to ask you a few questions about treatment for HIV. Treatment paradigms for HIV now have evolved so much in recent years. We are seeing increased use of generics, sometimes to save cost. We're seeing people moving from 3 drug regimens, sometimes 4 drug regimens, to 2 drug regimens, even as oral treatment, or perhaps increasingly as injectable therapy, as some of these longer acting treatments are finally becoming available. People obviously have many questions about these. How do you think we can better communicate about this change in sort of treatment options and treatment paradigms? And what kind of uncertainties and questions will this throw up for people who may have been, stable and established on treatment for a decade or more, and suddenly get thrown the uncertainty of switching treatment or a variety of new options that may be quite bewildering?
Tristan, I think that's such a great question. And it's such an interesting thing for us to unpick, because I think the starting point, we have to acknowledge that HIV treatment is complex, and it's complicated for 95% of us that take the pills, even those that work in healthcare settings or are clinicians. There's so much to understand. Most of us just take our pills and don't understand what's in them, that there are 3 drugs or whatever it is. So we might just pop 1 pill a day, and we're so happy and grateful. And those of us that have been on treatment for a really long time are happy that we've gone down to 1. And lots of people who started treatment in the past 5 or 6 years have started on 1 pill a day. So I think that what happens is that when individuals are told they may need to change their regime and increase the numbers of pills they're taking, the first question is this going to change the impact this has on my body and the effect it has on the HIV in my body? So we need to make sure we're educating and reassuring people what the medication is and what it does, and that it's no different. I think a lot of people, secondly, aren't really concerned about cost. They don't necessarily understand that health services cost money, and therefore treating HIV costs a lot of money. And we're not altruistic. We want the best stuff. We want it for ourselves. So I think there is a job that healthcare professionals need to do to reassure the people that they're seeing that this medication is just as effective. It works in exactly the same way. But then the third thing that we really need to be concerned about is that people do struggle to take treatment, either because of their social situations, if you're living in shared accommodation, if you're hiding your status, if you have children around, if you have children who are taking treatment. All of these things become really difficult for people. So it's how do we incorporate the changes into people's individual lives and circumstances? And this came to me recently in a group that I'm at with a group of positive men, and somebody was asked to go onto generics and was told by his doctors, simply, we're putting you on it because it's cheaper. And that made the person feel worthless, made them feel less than, whereas the clinician could have spent some time explaining why we need to make that cost, why they're more effective. So I circle right back again to the need for education, but also peer support. So if we have people who have had lived experience of moving from one treatment regime to a different one, who can talk that through with people, that could work wonders. But I think the final thing is always give people options on the table. So if the alternative to generics is to stay on your meds and you want to stay on your meds, then you should be allowed to stay on meds if at all possible.
Yeah, I agree it's complicated. I had someone earlier today actually who was switched about a month ago actually to a very well-priced regimen. It's not a cheap regimen. It's not a generic regimen at all. And he said, why was I moved to this? Was it just for cost? Now, it wasn't at all. He believed he'd been switched to something for cost. In actual fact, he'd been switched away from a boosted protease inhibitor for reasons of metabolic health and potential drug-drug interactions. But that was a really good example for me of how that switch, even if it had been explained at the time, in his head, he thought the only reason that we would switch him was for reasons of cost, when actually this was for very good medical reasons. So I think we do have to be careful about how we inform and educate people about the reasons for switch. I think we're also seeing, and we've seen this before in the HIV sector, that, sometimes we are guilty of the emperor's new clothes a little bit, and that new things are shiny and the old things quickly fall out of favor. But we do have some very good tried and tested regimens that have been around for a long time, where we, are able to predict side effects, toxicity or lack of toxicity. And sometimes the newer modalities of treatment don't have the longevity in terms of the track record to allow us to really predict what might happen to an individual person in front of us. So, new is not always better. Expensive is not necessarily always better. And again, this will vary according to what country you're in and how healthcare is provided. But the reassuring thing you've told me is that HIV treatment is complex, because you've just guaranteed that I still have a job, Mark. So thank you very much indeed for that.
Well, I've literally just written a piece on HIV treatment, and I was looking at the history and the timeline of how we've got from 1981 through injectables today. And there was just reams and reams and reams of stuff. So I think one of the great things about HIV treatment and science is it's constantly evolving. It's constantly moving forward. I was out yesterday and bumped into a young man who's on the trial at the moment for injectables, and he was so excited to be part of this because he struggled with adherence in the past. So for him, this is a great way forward.
I think it's interesting reflecting on how we offer new treatments and clinical trials as well. Injectables are really key for us at the moment because I think it remains the case that we're maybe being a little bit paternalistic about who we offer these to, in that we initially want it to be people that are undetectable, understand the need to come back for visits every 8 weeks, can attend, will attend. And, this in a way makes us look for the perfect person, if you like, to get injectables, rather than acknowledging that we're ready to now trial these in a real world experience in the same way we do with tablet medication, and find out what the pros and cons are for each individual that we prescribe for. So I think we have to be careful about making sure that we do offer things to people equitably, rather than sometimes kind of overthinking it, I think, from our side. And of course, no one wants anyone to fail a treatment or something to go wrong. But I think the same is also true of clinical trials, where we need to be very mindful of offering people new options, and again, doing that very equitably.
I mean, I'm very, very happy on my 1 pill a day at the moment and have been for a number of years. So if injectables do come my way, I will certainly consider them.
Okay. So I wonder if just we could reflect on some of the other, we've mentioned some of the reasons for changing antiretroviral therapy, including perhaps cost cutting, newer modalities and things. But how well do you think people understand the fact that what we sometimes do with long-term HIV treatment is we change things to try and maximize people's long-term health? We want to maximize their physical well-being. We want to make sure their mental health is good for the long term, their cognition is good. And often what we're trying to do, rather than unsettle people, is maximize their health-related quality of life. How well do you think that's understood in communities of people living with HIV?
Gosh, I'm so thrilled you asked that. I don't think it is understood at all. I think that we have done a left and we no longer talk in detail about those benefits of treatment and the wider reasons why we maximize treatment and why we change it. And I think that is because our focus has been on getting people to undetectable, and we stop. And so it's like you go in, you've got your viral load, it's undetectable. We might do your CD4 this year, we might not, but you're okay. And then when treatment options are offered to change, it's literally because we need to change them. And I think there is a much bigger conversation, more stuff that we should be putting out there about all of those reasons why we take treatment as positive people. And just hearing you say that alone, listing those things reminds me every morning when I pop the pill why I'm taking it. Because it isn't just about being undetectable, because I've been on medication since 2001. Viral load testing was being done, but my undetectability was a notice to me that I wasn't going to get ill, which meant that I could chill, which meant that my mental health got a bit better, which meant I can make plans for the future. I can enjoy my life. Whereas now it's much more, I'm not going to pass HIV on. That's the end of the conversation. So I think there's still work to be done.
This is really interesting, isn't it? Because you and I will know there have been many campaigns and straplines to events that have been about going beyond undetectable. What do we mean by that? What do we mean by health-related quality of life? Why we shouldn't just stop, the fourth 90, if you like, being quality of life, moving beyond just viral suppression as being the end target. And yet it sounds like this is something we're talking about in the HIV bubble, in a bit of an echo chamber, and perhaps not communicating this very well to the people that we're treating.
I'd agree with you. And I think if we did a straw poll of lots of positive people who were asked, if you went to your healthcare, when you last went to your healthcare provider, did they ask you these quality of life questions related to your treatment and how you feel about them, we would get much richer data and answers, which would inform your practice, healthcare professionals like yourself, but also grassroots community folk like me who are developing newly diagnosed programs, peer support programs, and up the coalface. So I think absolutely we need to kind of reconsider that.
So we've talked about a lot, Mark. Shall we try and think about some overarching themes in what we've discussed so far, I guess? Because what we're thinking about here, or trying to think about, is how we really do center care around people with HIV, if you like, from testing to early treatment through to treating for many decades and aging. So what key themes do you think we've identified today that people could, kind of ponder on and think about how we might do better?
I mean, one of the first things that leaps out to me, and I don't think this just applies to treatment of people living with HIV, this is about treating people who need healthcare, is that the person is center. We need a person-centered, holistic approach which looks at and takes on board the intersections of that individual's life. We've looked at that in testing. We can't have a one-size-fits-all when we're pushing testing and having testing out in the community. When we think about once people are engaging in care, having cookie-cutter services don't work, and we need to address that. So how are we providing services for women? How are we providing services for migrants? How are we serving migrants who are women who may also be LGBTQ? So these are the various factors. And then when we come to treatment, we know that we're all pretty much getting the same treatment, but it impacts on our lives differently. So for me, number one is definitely person-centered approaches and holistic care.
Thank you. I really agree with that. I think the other big thing that's leaping out for me is how we promote and sell, if you like, the benefits of not only of testing to a wider group of people, perhaps people who've not heard the positive messages of what it means to know your HIV status before, but also how we inform people about the benefits of all HIV therapy. And what I mean by that is we know we can achieve viral undetectability. We've got that. It's in the bag. What we need to do now is look at how we best use all of these tools to maximize your health outcomes for the long term, because that's how I see my role increasingly, but maybe I'm not communicating that so well to the people for whom I'm providing treatment. So how do we use the tools we have, not only to get you undetectable, that bit's easy, but what we need to do is now tweak and change and perfect and sculpt and mold and make sure that we're doing the best for you to have the best health-related quality of life over many decades.
Yeah. And I would say the third thing is about the fourth 90, is about quality of life. We cannot achieve any of these things that we're talking about here today without considering how they fit in and improve an individual and therefore a community's quality of life. And that means taking on board socioeconomic factors, issues around ethnicity, race and sexuality and sex. These are all things which make us up. And these are the things which we present when we come into a healthcare setting. So quality of life is incredibly, incredibly important, I think.
Mark, it is always a great delight talking to you. Thank you for spending this time thinking about ways that we can really improve access to HIV care, testing, getting onto that HIV journey, and then how we can truly be person-centered to maximize not only biological outcomes and virologic outcomes, but also quality of life, metabolic health for the long term in different communities and different people with truly person-centered services. It really has been a delight. Thank you so much.
Oh, and likewise, Tristan, it's always a pleasure to catch up with you. And I also want to acknowledge that, that clinicians and healthcare professionals like yourself and people who will be listening in on this are incredibly busy and are doing a great job under a lot of pressure with sometimes really difficult and challenging circumstances. So I hope that people enjoyed what we say and they take from it and they're able to develop really good practice to meet the needs of positive people like myself and others around the community.
Thank you very much to Mark and Tristan, and thank you to our listeners for joining in. Please be sure to check back regularly for more episodes on important infectious disease topics, including more regionally focused episodes on what patients want in HIV treatment and prevention. Thank you and have a great day.